Hello everyone, and welcome to this session on faster and earlier diagnosis of cancer. Now, more people are surviving cancer after NHS treatment than 3 years ago, which is great. How can we continue this progress? Faster and earlier diagnosis helps the NHS as an organisation, its use of resources, and makes the difference to the individual. And we're going to focus on how we change pathways to achieve this and how the alliances are driving the transformation of how we deliver cancer care, showcasing some of the ways they're doing this. So let me introduce the panel. We have Chris Harrison, he's going to be the chair. He's the National Clinical Director for Cancer. Professor Hashim Ahmed, Consultant Urological Surgeon, Imperial College Healthcare NHS Trust. We have Dr. Phil Crosbie, Consultant in Respiratory Medicine, the University Hospital of South Manchester. Mike Thorpe, a former cancer patient himself. Amanda Lyons, Director for Delivery and Improvement, South Central NHS Improvement. And Nigel Acheson, Regional Medical Director for the South for NHS England. I'll hand over to the chair, Chris.
Thank you, and welcome. It's a rather long room, so I'm going to try and look around from side to side. I feel probably a little bit like I'm at Wimbledon as I've got there. But welcome everybody to this session. The introductions have been done, but I just want to make a few comments by way of introduction. Not seeming to move on. Can you help me? There we are. Thank you. I'm here as National Clinical Director for Cancer. As you'll be able to tell by the way I'm speaking, I'm also from the Northwest, from Manchester actually, and also here as Medical Director of the Christie Hospital in Manchester. And I'm involved in the National Cancer Programme because we have a National Cancer Plan, which is a fantastic opportunity to improve cancer care in England. We do have some fantastic and excellent services already, but with the plan that we have, by 2020, we are in a position, I think, to be able to improve what we do and to catch up with many other places in the world. I think we're going to be doing the right things, and as you'll see if you listen to some of the other presentations on other stages today, there's some quite radical proposals in what's going to happen. What we have in place now is the return of local coordination and leadership for cancer at a level that used to be provided, I think, by many of the cancer networks. We have now 16 cancer alliances and 3 vanguard partnership areas, so 19 areas altogether across England that are the engine rooms, the drivers for improvements in cancer care locally. And I think, you know, these have been put in place over the last 12 months and are going to be an essential building block for the future. A lot of what we're going to talk about this afternoon revolves around early and faster diagnosis of cancer. And on this slide you see the 4 areas that through the National Transformation Fund, £200 million over 2 years, we're seeking to promote and drive forward. I won't talk through the details of all these. We're going to touch on some of them as the session goes on. But what we are trying to do is ensure that there's a consistency in the way that the cancer alliances implement approaches to early and faster diagnosis. And I use those 2 words deliberately and draw that distinction between early, which is getting people into our cancer system at an earlier stage in their disease, their condition, and faster, which is once people are in the system, that we do the things we need to do to both diagnose and treat people. The National Transformation Funding is £200 million. It is linked very much to early diagnosis of cancer and also to achieving important national targets. It's also linked very much to the objective of improving cancer care for people who are living with and beyond cancer. You'll recall that the national strategy puts this on a par with survival. So we're going to hear now from our speakers. We're going to hear something about achievements of national targets, and then we're going to go on to hear about prostate cancer, and we're going to hear about lung cancer and innovative approaches that are being taken, particularly to the earlier and the faster diagnosis of those conditions. So I'd like first of all to introduce Amanda and Nigel. What I should say is that we will have slot for some questions towards the end of the session. So please be thinking of questions as we go along, and we'll have a few minutes right at the end for those questions to be taken. So Amanda and Nigel are going to start, and I'll hand over to them.
Thank you.
As Chris said, I'm Amanda Lyons. I'm one of the directors of delivery and improvement for NHS Improvement, but I'm also the SRO for the South Region's recovery of the 62-day cancer standard. This is a joint programme working very closely with my colleague Nigel, but I'm unusually a chartered accountant by background, but have worked with the NHS for many years and enjoying the opportunity to work in this more clinical field. I think Nigel's going to introduce himself and then we'll carry on telling you about our journey.
Thank you. So, yeah, I'm Nigel Acheson. I'm Regional Medical Director for NHS England across the south of England. And my background is that I'm a gynae oncologist. And I'm also the son of somebody who's just gone through a breast cancer pathway and gone beyond the first year of follow-up. So the question of 62 days, why is it important to patients, is absolutely pertinent to me at the moment, as somebody who's had a very close family member go through the worry of finding something that's wrong and going to have investigation for that and wanting to understand exactly what will then follow. And certainly in my own clinical practice, I must confess I always saw the 62 days as something of a backstop rather than a standard. What I think we're trying to achieve together are a number of things. As Chris has mentioned, there are 4 key planks to what we're trying to do together around some pathway redesign, and we'll talk a little bit about that, about improved diagnostics for people who've got worrying symptoms. But actually what we want to try and do for almost everything is bundle those investigations up into as short a time frame as we can in order to be able to make a decision, a diagnosis, and then a decision about what treatments are right for patients. And as far as our approach has gone, we've tried to do some technical things, which you'll hear about shortly, and then we've tried to do some clinical engagement with, as Chris said, the colleagues who work as part of our cancer alliances. So we'll pick up the elements of our strategy as we go on.
Yeah, no worries. Now, I'm legendary with technology. Can we just go back to let's just go back to the slide, hang on with the alliances in the centre. Yeah, that's it. Fantastic. So when we were posed with the question as to how in the south are you going to recover the 62-day standard, which has been, at our fingertips, but not quite there for quite a long time, we looked at the fact, what had we got available to us to do that? We also considered that really this is a team effort. And hearing what Chris said with the alliances being very much a new area, something which is important to the transformation of of cancer across the country, it was for us that actually the cancer alliances were to be the centre of how we were going to work. Over the last few months, this has very much become a collaboration. We see the benefits for us, both NHS and Improvement and NHS England, working around the same table as the alliances and the providers and the commissioners to achieve a single aim has actually already borne fruits in terms of actually the establishment and the importance of the cancer alliances locally through this process is becoming very, very apparent to us. And we see this as a way to actually facilitate the ongoing success, not just for the next few months while everybody's putting their feet into, their back into it, but actually for the future. And that's why we choose to do what we choose to do. It's just... So, being someone from NHS Improvement, and NHS England, we couldn't but fail to share with you a few statistics. But actually, the 62-day cancer recovery programme is very much focused on four tumour pathways: lung, prostate, upper and lower GI. And when I first joined the programme and was asked to look at that, I wasn't certain I fully understood why that would be, but actually the graphs that you will see in front of you very much demonstrated it in an instance to me why it was that we chose to look at these four tumour pathways, and why you'll hear later as to the work that's going on in that area. You will see that although there has been a gradual decline in the achievement of the 62-day pathway standard for overall, actually the decline has been far sharper, and the performance overall in each of those individual pathways is far lower than we would all want to know and understand, and for our family members, if that were the case, to experience. So, and this just shows, it's quite detailed, but the deterioration is bigger in those four areas, but I won't dwell on that one too long. I'm not good with, there we go. Nigel referred to the three main elements that we have to the programme to recover our standard. And as you'd expect, we've got we call it getting your house in order. Effectively, grip and control is the first phase of that. Then we want to make sure that across the south that we meet best practice where we can, and then we want to transform our care. I'm going to talk a little bit about getting the house in order, and then Nigel will spend much more time just explaining some of the work that we're doing in the best practice areas. So for us, the getting your house in order is very much focused at the providers and then looking across between providers. And working with the providers, we have some good practice that we've identified. So virtual daily PTL huddles. This is from Maidstone and Tunbridge Wells. We've got a trust that's done I call it a cancer reboot. I don't think that's quite the same way, but across the board, they've done a launch event in the same way that you would, if you were in the urgent care world, do a perfect week. They've done this with cancer. And one of our other trusts that has been through this journey already and gone from across the board suboptimal 62-day performance has put in a whole phase of good governance and process controls, and they have recovered the standard across all their tumour groups. So Royal Berkshire spoke at NHS Improvements conference back in July, and I'm sure would be more than happy to share their experience. Nigel, with his clinical background, is now going to talk much more about best practice pathways and transforming care.
Thanks, Amanda. So just very briefly, what the Cancer Alliances have allowed us to do very rapidly is to try and reinvigorate some of the clinical networking arrangements that existed a number of years ago. And you'll hear about some of the work that's absolutely pioneering later on. But what we've been doing is we've been trying to gather best practice from colleagues such as those on the panel here. We've been trying to do our timed pathways for each of those four specialties across the region to give us a baseline. And what we've done is identified leads in each of our 6 cancer alliances in the south, linked those colleagues up, and each of the alliances is taking a bit of a lead on one of those areas, although obviously they're working on them all. And what we're hoping also is that people will begin to feel that they are responsible for patients across a population rather than just a bit of a patient pathway in their own institution, and that's something that we're actively trying to help our colleagues work on. And then this transforming care is the idea about how can we do bits of the pathway differently, how can we bundle up some of our investigations, the one-stop approach that some of you will be familiar with, how can we maybe make some of our pathways non-linear. If there are elements that can be done in one place, say pathology or radiology reporting, then let's explore how we might exploit those. And that has given us this idea, or the red to green, which is, you know, what we don't want are days or weeks with nothing happening, when actually we could be helping to try and shorten the patient's pathway by expediting some of the investigations. So that work's ongoing. I must say we're getting a lot of support from our clinical colleagues for that element in support of the work that Amanda suggested. So Chris, that's an outline of our approach in the South.
Thank you, Nigel. Thank you, Amanda. So clearly, what we've got is a set of structures and the delivery mechanism in the alliances, and a great deal of enthusiasm and focus through the regional teams. What we're now going to go on here, though, is from people who are involved in transformation at a local level, and some real examples of that. Professor Hashim Ahmed is going to go next. Hashim and I were just conferring notes that he started at Imperial Healthcare probably just as I left. So we haven't actually met each other previously, but we both have worked at Imperial Healthcare in London. And Hashim is going to talk to us about work that's been done, particularly on the prostate cancer pathway. And then importantly, we've got Mike Thorpe, one of the patients actually from Manchester, who's going to not use slides, but is going to make some comments for us following Hashim's presentation. We're just sorting out the
Okay,
machine is a bit sticky.
Thank you very much.
It doesn't quite move on fast enough when you're speaking. So.
Thank you very much. I've just been told the clicker doesn't work, so I have to put my hand
It doesn't
down.
work at all. Oh.
Yeah, every time I want the slides to move on.
There
so
we,
it's
there
not
we are,
because I have
well,
a
pressing it
tick or
faster and
anything.
faster.
Thank you for asking me to talk today. I'm an academic urologist. I moved to Imperial in March 2017, and prior to that I was at University College London. And I'm going to talk about a project which involves a huge number of people, and I can't mention them all, but it's a real team effort, and it's a regional effort in London across the major and the other DGH centres as well. We've had, next slide please, I'll just say next slide. So I'm going to talk about something that we have received funding for from the Transformation Fund, delivered through RM Partners and Imperial. Prostate cancer is a growing health burden. We think almost double the numbers by 2030 in terms of incidence because of increased awareness, increased testing in the community using a blood test called PSA. And if that blood test is elevated, men are referred into hospital. Next slide, please. And they undergo a biopsy. That biopsy is through the rectum, and it is essentially a random biopsy that places needles into the prostate in the hope of hitting the cancer. Click forward again, please. And what that means is that we find cancers that shouldn't be treated because they don't cause any harm. We miss cancers that should be treated and might progress because they've been missed. And we misclassify important as unimportant and potentially undertreat. And like in breast cancer, we still treat the majority of men, if they need treatment and choose treatment, to the whole prostate, and that can cause collateral tissue damage and harms. This is going on across the world. This is not just UK. About 1 million men in Europe and another 1 million in the US undergo this biopsy test every year. Next slide, please. We've now got robust data to show that imaging using MRI can identify most of the important cancers that are likely to progress. We have the technology that allows users, operators, to place a needle accurately in the right place. And that means we find the important cancers. We tend to avoid the unimportant cancers that half the men in this audience have, but don't know about, and hopefully will never know about. And going forward, we have the technology to do the equivalent of male lumpectomy, which I won't talk about today. Next slide, please. So this is an MRI scan, a man lying on his back. The bottom of the slide is his back. The top of the slide is his front tummy. And the prostate, this probably doesn't work. It does. There's the prostate. And that area, you have to believe me, is his tumor. Because when we biopsied that area, it came back as tumor. When we biopsied the rest of the prostate, there was nothing more than tiny, low-risk cancers that half of the male population here have, and we don't want to find. So MRI finds the significant disease. Next slide, please. And we can take those MRI images and, using technology that has been worked up in academic centers across the world, we can create models of the prostate itself. The prostate moves around, and we need to be able to mold it to when we do a biopsy. And very powerful software allows us to do that. Next slide. So that when you have a biopsy, the biopsy probe, which is an ultrasound, not an MRI scanner, deforms the prostate. And you need to be able to deform the MRI images in the same way. Next slide. And so when you do your biopsy in the clinic or in the procedure suite, you're using ultrasound images, which are less accurate, but you're then able to fuse the MRI images live and deform it to the contours of the prostate. And so big is this market that there are about 10 plus commercial companies developing software that does this. Next slide. And then once you do this, you're able to allow a surgeon like myself, who's not very bright and very clever, to place a needle into the red blob. They don't need to think about where the tumor is. They're shown a red blob. And you're able to increase the accuracy. And by not taking random biopsies, you're not finding those tiny little bits of cancer, which then men get worried about and then have treatment which is harmful. Next slide. And we did a big study called PROMISE, supported by the NIHR. It was a pivotal study that's now changed practice across the world and showed that MRI is almost twice as good at finding important cancers. And when the MRI is clear, men can avoid an immediate biopsy. So critically, about a quarter to a third of men can avoid a biopsy altogether. And that's where the health economic benefits come from. Next slide. So the new pathway, and the challenge is delivering this new pathway, not arguing about whether it is correct or not, is this. So that men have an MRI, an imaging test, like a manogram, if you like, and then a targeted biopsy. And if it's negative, the men do not get a biopsy. Next slide. But there's problems around this, and we're working with a stakeholder organization, Prostate Cancer UK, as well as NHS England, to try and bring in something similar to mammography screening. We don't have prostate cancer screening, so this can't be government mandated like it is in breast cancer. But we need a way of quality assuring the scans so that everybody does the same, that everybody reports the same, that if there are outlying radiologists or urologists, we can identify them and support them to improve or eventually stop them doing things, and look at rates of unnecessary treatment, because that's a big issue as well. Next slide. And so the RM Partners Imperial Rapid program is going to look at 3 pilot sites in West London, where we're going to do all of this within 1 day. So they're all going to come in, have an MRI in the morning, takes about 30 minutes. It's all going to be reported that same morning with a pictorial diagram. And if they have a lesion, they will be seen in clinic, shown a diagram of their MRI, and told that they need a biopsy. And if they don't need a biopsy, they will be discharged immediately with advice to the GP on follow-up testing. And this is taking multiple steps that were taking between 4 and 8 weeks to deliver. A great pathway, but multiple steps condensed into one day. Next slide. And because trusts which were trying to adopt MRI pre-biopsy were starting to actually breach as a result of this new test, we needed to identify a way to help them. And the only way to do this is to try and condense it all as much as possible into one day. And we had resistance because people said, well, we can't do this. But actually, they were doing the MRIs that they were always going to do. They just needed to front-load the system. The radiologists were always going to do the same work that they've been asked to do, but they just need to do it on the day that the MRI scan has been done. The urologists always need to see the patient and do the biopsy. They just needed to do it on the same day as the MRI. And so it didn't take much convincing because ultimately people were still doing the same work that they were doing, but the improvements were massive. And in fact, in clinical practice, we saw 40% of men being able to avoid an immediate biopsy. And we do approximately about 120 to 150,000 prostate biopsies every year in the UK. Next slide. So in conclusion, the standard approach to diagnosing prostate cancer is currently blind to location of the cancer. The standard approach to diagnosing prostate cancer leads to unnecessary harms. This happens across the world. The new pathway has to include prostate MRI, and this can allow up to a third of men to avoid an unnecessary biopsy safely. And if they need a biopsy, it's much more accurate than the traditional one. There is a considerable amount in terms of challenges with delivery, capacity, and transformation of our pathways to allow dissemination across the NHS so that every man and every year that we go on where we don't deliver this pathway, that's tens of thousands of men that don't have access to the highest quality diagnostics. So there is a challenge in dissemination. And we hope by this pilot that we will be able to demonstrate to our colleagues across the country that this is doable, deliverable, and actually will massively improve their pathway and their cancer waiting time targets. Thank you.
Thank you very much. Now, Mike, over to you.
Well, from a patient perspective, all I can say is, wow, that was just unbelievable. It's the first time today I'd actually heard the details of this, and bizarrely been working on it for the Vanguard with the Urology Pathway Boards of London and Manchester. So to actually get the MRI scan and the biopsies done in a day is just unbelievable. My personal journey, if you like, and not everyone likes the word journey, but that I went through it in one day with ultrasound, biopsies, the full hit. I had a CT scan eventually, which wasn't clear. So I ended up with an MRI scan, which I actually blame for having the situation that got me through treatment and radiotherapy as well as it did do. I am down as a former patient. I asked for that slide to actually be former Christie patient, because I got discharged from there on the 28th of July this year. And you're put into aftercare, it doesn't mean you're cured, but I put that down to the way things have been with radiotherapy being more accurate, down to the fact that I'd had an MRI scan. But the biopsy is, as a patient, I think I can see some of the men in here and the looks on the faces, they have an idea what it is, and you didn't get a real clear view of how it's taken. I think we can safely call it barbaric. You know, it really is an unpleasant experience. But it gets results at the moment, and everyone's doing it. But if we're going to change that, the sooner the better. From a patient point of view, we need this. Onwards with it, like I say, with the Vanguard, the way it's worked out is tomorrow morning we've actually got a meeting about Hashim's system, trying to put a Vanguard project together about that. I've got 3 hours tomorrow morning, so I'm going to be late, I'm afraid. But yes, we're actually working on it, and hopefully we can justify the cost, we can resource it. We know about radiographers, about scanners, getting the equipment. It's not going to be cheap, but hopefully it'll save more money. But the most important thing you need to look for is patient outcomes. You save 30% of biopsies, that's 30% of the men who will vote for this straight away. Thanks a lot.
Thank you very much. Thank you. So we've heard both the patient perspective and also the professional perspective on that particular innovation. I'm going to move us on now, before we have questions, to Phil, who will introduce himself, but Phil is slightly more local and will tell us all about developments in lung cancer. Phil.
Does this work? Thank you very much for inviting me to speak. So I'm a local chest physician with Wythenshawe Hospital, and I'd like to tell you about a pilot we've done, pilot in lung cancer screening. Next slide, please. So we looked into the causes of premature death in Manchester, and you can see there that we have heart disease, lung disease, and cancers. But actually, next slide, please. If you look at the leading cause of premature death, lung cancer is the single leading cause of premature death, and premature death is any cause of death under the age of 75, which was a real surprise. And of course, that may be specific to Manchester because of levels of deprivation and smoking. But next slide, please. If you look across the UK, there's also lung cancer is the second leading cause of premature death. So it's not just in Manchester, it is a UK-wide issue, and actually a worldwide issue. Lung cancer is the leading cause of cancer death. Next slide, please. Just very simply, lung cancer is staged from stage 1 to stage 4. Stage 1 is early stage disease, a small localized tumor. Stage 4 is advanced disease with spread into distant organs. Next slide, please. There we go. And so currently in Greater Manchester, this is a staged distribution of patients when they first walk through the clinic door. So 75% have advanced disease. So stage 4 is unfortunately pretty much incurable. Stage 1, it has a very good cure rate, and especially the early stage ones. So when a patient walks into my clinic room, on average, half will die within 250 days because they present with very advanced disease in general. Critical to outcome is early detection. Next slide, please. So we set up a lung cancer screening pilot. Now, evidence for lung cancer screening comes from the National Lung Screening Trial, which showed a 20% reduction in lung cancer-specific mortality. So we have the evidence that it works. What we needed to show is whether we could implement it. And Macmillan were fantastic and provided funding for the pilot. The service design, we picked out 4 or 5 key features of the design that we thought would make it successful. So that was community-based. It needed to be where people were. It needed to be in deprived areas because that's where most lung cancer is. And with patient groups, it needed to be to a lung health check, not to lung cancer screening, because it was felt that it would put quite a few people off if we called it lung cancer screening. We know it reduces harm if you target those most at risk. So there's a validated risk score that you use really to choose those smokers who are most at risk. And we also wanted it to be accessible and convenient. So we had it in a supermarket, car park, and immediately next door was a mobile scanner. And so when a person turned up to the lung health check, they had a few questions about symptoms, questions about lung cancer risk, smoking, and a few other bits and pieces. Next slide, please. There was a very detailed engagement approach that Macmillan did for the whole of the service, from design to delivery, and that was very, very valuable. Next slide, please. So the lung health check, there's just a few pictures there. This is in Harper Hay, which is North Manchester. The support truck and the CT scanner next door in a car park. And we had 2,500 people attend. The very, very surprising thing, because when we were doing this, we were told it's a waste of money, you shouldn't do this because people won't turn up, is that actually when we sent the invites out, the call center could not cope with the demand. There were thousands of phone calls they could not answer because demand was so high. So in the health check, they looked at symptoms, spirometry, smoking advice, and also lung cancer risk. If you were high risk, then you went immediately to have a CT scan, and 1,300 people had a scan. Next slide, please. This is just really I suppose the naysayers at the beginning of the process said don't bother because people won't turn up, and therefore labelled people in deprived areas as hard to reach. But actually, the deprivation indices, because we went into local communities, we set the service up appropriately, then we had a huge amount of demand from those communities. So it basically says reaching the hard to reach is not the right wording. You actually have to design your service appropriately. Next slide, please. So when you do screening, you do a low-dose CT scan to reduce the radiation exposure to a minimum. And from a clinical perspective, you get 3 outcomes. You either get a negative scan, and then you don't have to do anything. They just come back for the next screening round. You have an indeterminate scan where you may have a nodule that needs follow-up, and those individuals have to have a 3-month scan, or you have a positive scan, and those people are at risk of lung cancer. You're worried about lung cancer. They have to come into the cancer clinic. So we had about 6% of people we were worried about cancer, and about half of those did have cancer. So 81 people came into the clinic, 42 had lung cancer, 39 did not. Next slide, please. And the people who came into the cancer clinic but did not have cancer are classified as a false positive. And what we've done here is just put a table where you can compare our false positive rates with the leading international studies in lung cancer screening. And the reason to do that is because we were simply an NHS service. We didn't have any additional funding for the service in the hospital. But actually our results are comparable to these leading international studies. So our false positive rate was low. The number of investigations we had to do in people without cancer was low, and the complication rate was virtually 0. Next slide, please. So again, comparing with other international groups, the prevalence of lung cancer in our screening study was 3%. So that's a cancer detected for every 33 scans. And that's 3 times higher than the other international studies. And that's because we went to the right place and we went into the right communities. Next slide, please. So the important thing, as I said at the beginning, is the stage of lung cancer at diagnosis. When the patient is in the clinic room, their survival depends on stage. Next slide. When you compare screen-detected lung cancer with standard detected lung cancer, there's a massive difference, and essentially you turn everything on its head. Symptomatic lung cancer, which comes through the normal pathways, is almost always advanced disease, or the majority is. Screen-detected cancer is almost always early-stage disease. And so that absolutely transforms outcomes and, we hope, saves a lot of lives. Next slide, please. Treatment is complicated for lung cancer, but the bottom line is the surgery is for early stage disease is the gold standard, and our surgical resection rate was 64%, and that's 4-fold higher than the national average of 16%. And 9 out of 10 people were offered curative treatment, which is significantly higher than normal. Next slide, please. So it looks to be a clinically effective intervention, and we had independent analysis to look at it as to whether it was cost effective, and the conclusion was that it was, based on an incremental cost effectiveness ratio of £10,000 per QALY, which is well below the NICE threshold. And that doesn't include, that's just based on cancer. It doesn't include additional benefits such as smoking cessation, detection of other diseases, and cardiovascular disease. Next slide, please. I won't go through this in detail, but because a scan is a scan of the thorax, you are not just looking for cancer. So you pick up other illnesses. For instance, interstitial lung disease is a very serious condition, and we picked up a significant number of patients with that condition, and they have been assessed in our interstitial lung disease MDT, and we'll find out whether that also introduces a stage shift. And there's additional things, additional cancers, aneurysms in almost 1%, people who needed immediate treatment or surveillance for aneurysms. And also cardiovascular disease, I think this is a major benefit, and a lot of people will benefit from preventative treatment that we would be able to advise the GP on. Next slide, please. So we also asked people that took part in the actual service, and the feedback was excellent. 97% said they would recommend the service to a friend or family member. Next slide, please. So that's really just to give you a brief overview. We think we've got a clinically effective intervention. It's cost effective, and it's very acceptable to people that took part. To deliver it took a very big team, and I'm presenting on behalf of the team, and I'd like to acknowledge everybody on that slide. Thank you very much.
So I think we started slightly late, so I think we're going to have a few minutes for questions. But could I just ask you to thank our speakers following those presentations? I have got a few questions, but I would prefer it if there were questions from the audience. Have we got any questions from the audience at all? We've got a gentleman at the back and a gentleman at the front. We'll start at the front because you've got the microphone first, so we'll go to the back.
Hugh Riseborough. I mean, it's fascinating and great to see, I guess, the kind of one-stop shop solution and the early detection. But I suppose if we look at the cancer performance in the UK, how much of it is about capacity and resources, and how much of it is just about getting the process right, as you have done in those two examples? I mean, could we use the same resources better in the way you have and just get massively better outcomes at a level with international best practice?
Okay, thank you. We've got that question. Would you like to ask your question at the back as well? Then we'll perhaps...
Hi, it's Peter Whittington from the Office for Life Sciences. Both about the prostate detector and also the lung cancer one, whether you'd looked at, they were both scanner-based approaches, whether you'd looked at this, is there a relevant biomarker you could assess, or in relation to the lung cancer one, there's a solid state breath sensor that's been developed in the east of England, whether you'd looked at that by Owlstone.
Okay. Any questions from this end of the room at all? No. So I think perhaps we come first off onto the question about resources and capacity. I mean, the question is it just about realigning what we currently have, or is it about an expansion of capacity that's required? Yeah, to say from a sort of point of view?
So I think there are a number of aspects to this. I think the one of the things that I think Chris alluded to is that we've got a number of challenges. So in addition to some of the wonderful diagnostic tests and so on that we're doing, we also now know what causes a number of cancers. So we can prevent, ultimately, best case scenario, 4 out of 10. So there's an immense effort on the prevention side, and that absolutely has to be part of any conversation any of us have, because there are some simple things that we can all do. At the other side, because of the success of some of the treatments of colleagues on the panel, we've got about 2.5 million people living with and beyond diagnosis of cancer at the minute. That's going to go up to 4.5 million. So we need to have some resource to manage their psychological, physical, and cancer-related health afterwards. The question then is, can we use our resource smarter, if you like? And I think the answer is undoubtedly yes. And you know, some of the innovations that you've heard about today are things that we would very much like to introduce across the piece. One of the reasons why I'm doing what I'm doing is, and I think we'd all agree, there is variation which we can drive out, and in fact it's the theme through many of the talks here. Some of that is about, I mentioned in the little piece that I talked about, trying to get colleagues to think in a slightly non-linear way, so that if you see somebody and you're going to refer them on, are there ways that they can have the pre-operative testing, that sort of thing, done at the time? Gives you slightly longer. If there's some optimization that needs to happen for a patient, it hopefully will reduce the cancellations at the last minute. So yes, there's a huge amount of getting that bit of the pathway optimized, I think we can do. I really do.
Yeah, I mean, I guess somebody's been trying to do it for 30 years or so, you know, you can see how the system could be changed, but it's getting the momentum in the system and getting the space in the system to achieve that change. So for me, it's a bit of both. I mean, there are clearly areas where, you know, I think any rational assessment shows we're going to need to increase capacity, but there are clearly, you can do that by swapping around, but that's, as we all know, is not easy. It's not straightforward. Which I think is why it's called the Transformation Fund. What we have is, that's the aim, is to be able to achieve that objective. Now, Phil, probably, would you want to answer the biomarker question. So the question really is, in addition to the imaging, are there some other forms, other biomarker forms that are going to be useful in addition to the imaging tests?
Yeah, so nothing in clinical practice. So there's no biomarker that we can use now, but there's a lot of research going into it in terms of bloodborne and also breath. So Owlstone, the breath analyzer, we are trialing in our clinic for early detection. So yeah, huge amount of time and funding into the research of it, but it's not at the clinical interface yet.
I mean, certainly from my perspective, there seems to be a large number of potential areas in this field, a large number of companies that have potential areas. You know, the issue now is getting them tested and getting them tested in the real world clinical practice, I think, and that is something that the vanguards and some of the other alliances actually are beginning to start to test. And I think I've got the no, so I think we're going to have to come to an end. But thank you to the audience. Sorry there wasn't time for a few more questions. Thank you again to the panellists for their
Yes, please join me in a round of applause for our panel and for our chair, Chris.